In women, estrogen is produced by multiple sources. In premenopausal women, most estrogen is produced by the ovaries. However, after menopause, the overall amount of estrogen produced by the body is reduced, and the major source of estrogen production shifts to other parts of the body. In postmenopausal women, estrogen precursors, or androgens, are predominantly produced in the adrenal glands. After they are produced in the adrenals, the androgens circulate through the body, where they are converted to estrogen. This occurs in a number of sites, including adipose tissue, the breast, and bone. The enzyme aromatase catalyzes the conversion of androgens to estrogen. The newly synthesized estrogen can exert its effects locally or can enter the bloodstream and circulate throughout the body. In breast tissue, estrogen can contribute to the development and growth of breast cancer that expresses the estrogen receptor by activating estrogen receptor signaling pathways. Estrogen crosses the cell membrane of the breast cancer cell, where it encounters the estrogen receptor in those tumors that are estrogen receptor positive. This interaction can occur in either the cytoplasm or the nucleus. Faslodex fulvestrant injection blocks estrogen binding at the receptor level and inhibits estrogen receptor-stimulated signaling. This process results from Faslodex reversibly binding to the estrogen receptor. Faslodex binding leads to a conformational change in the receptor that renders both the AF1 and AF2 domains inactive. In addition to blocking the binding of estrogen, Faslodex also inhibits receptor dimerization and translocation to the nucleus and accelerates degradation of the estrogen receptor. Faslodex exhibits no known agonist effects. As a result, estrogen-stimulated cell division is inhibited. Important safety information about Faslodex fulvestrant injection. Faslodex is contraindicated in patients with known hypersensitivity to the drug or to any of its components. Hypersensitivity reactions, including urticaria and angioedema, have been reported in association with Faslodex. Because Faslodex is administered intramuscularly, it should be used with caution in patients with bleeding diatheses, thrombocytopenia, or in patients on anticoagulants. Faslodex is metabolized primarily in the liver. A 250 mg dose is recommended in patients with moderate hepatic impairment. Faslodex has not been evaluated in patients with severe hepatic impairment, Child-Pugh Class C. Fetal harm can occur when administered to a pregnant woman. Women should be advised of the potential hazard to the fetus and to avoid becoming pregnant while receiving Faslodex. The most common clinically significant adverse reactions occurring in greater than or equal to 5% of patients receiving Faslodex were injection site pain, nausea, bone pain, arthralgia, headache, back pain, fatigue, pain in extremity, hot flash, vomiting, anorexia, asthenia, musculoskeletal pain, cough, dyspnea, and constipation. Increased hepatic enzymes, ALT, AST, ALP, occurred in greater than 15% of Faslodex users and were non-dose dependent. Approved use for Faslodex. Faslodex is indicated for the treatment of hormone receptor-positive metastatic breast cancer in postmenopausal women with disease progression following anti-estrogen therapy. Please see Faslodex full prescribing information.